Today I'm here with my friend, colleague, and toxicologist, Dr. Bryan Judge, and we're going to be talking about cyanide toxicity. This is a topic that I know many of you are passionate about and that we all could learn more. Bryan, obviously you have a lot of roles as a toxicologist and emergency physician. Can you tell us a little bit about your background and training and what exactly a toxicologist does?
Sure, Todd. I'm a medical toxicologist. I did a 2-year fellowship after my emergency medicine residency. I trained at Indiana University and then came back to Grand Rapids and set up or helped establish a clinical toxicology service. And so it's really evaluating and treating poison patients at the bedside, which would include also evaluation of smoke inhalation victims who've been exposed to carbon monoxide and potentially cyanide as well.
We know that cyanide toxicity is not common. Can you tell us a little bit more about the frequency of cyanide toxicity and the chemical nature? What happens with cyanide toxicity?
Absolutely. It's fortunate that cyanide toxicity is not very frequent because it is one of the most potent toxins known to man. A very small amount can kill very quickly. It is a carbon molecule that it's triple bonded to a nitrogen molecule that really wreaks havoc at the cellular level and kills almost instantaneously depending on how that person is exposed to cyanide. I've probably encountered less than half a dozen potentially cyanide poisoned patients in my 20-year career as a medical toxicologist. And if there is a significant exposure to cyanide, usually in the form of a fire, where carbon material and nitrogen materials are burned, it will generate cyanide gas, and it can render a patient unconscious and kill them within a matter of minutes. Burned, it will generate cyanide gas, and it can render a patient unconscious and kill them within a matter of minutes.
I know that you mentioned that you've treated approximately 20 patients in your career as a toxicologist. I know that you've shared some data on the national prevalence of cyanide toxicity. Could you share a little bit more of that information?
Oh, absolutely. Probably less than a half dozen patients actually for cyanide poisoning. Because if there is, again, I want to stress that if there's a significant exposure to cyanide, it's going to kill that person almost instantly, and they won't be salvageable. But in terms of national data related to cyanide poisoning or toxicity, there's about a case a day that is reported to our national poison data system. So over the last 10 years, there's been about 3,500 potential cyanide poison victims reported to this database.
Obviously, the treatment of cyanide toxicity has changed in my time as an emergency physician. Could you take us through kind of our previous treatments for cyanide toxicity and what you're using currently as a toxicologist?
Sure. There's actually a couple different treatments for cyanide poisoning. The old treatment was the Lilly cyanide kit, which is no longer manufactured. And the way that the Lilly cyanide kit worked was to administer a nitrate, so amyl nitrate and sodium nitrate. You would give amyl nitrate through inhalation, and then sodium nitrate through IV, and then that would create what's called methemoglobin. And the methemoglobin has an iron molecule in it in a state that it avidly attracts cyanide, and then it forms an inactive compound that's then excreted in the urine. We also would give sodium thiosulfate as well as a sulfur donor to an enzyme known as rhodinase, which is very prevalent in the liver and muscle tissue that helps detoxify cyanide. There's a very minor pathway of cyanide detoxification through a vitamin B12 precursor known as hydroxycobalamin. And that has been used for, almost 40 years now over in Europe. And then it started gaining wider spread acceptance and use in the United States as a modality to treat cyanide poisoning or potential cyanide poisoning. The side effects are not as great, particularly in terms of affecting oxygen carrying capacity in somebody who might have developed carbon monoxide poisoning concomitantly with their cyanide poisoning.
If I called you with a patient who I thought had significant cyanide toxicity, what treatment would you tell me to perform for that patient?
I would recommend, if it's available, Cyanokit, which is hydroxycobalamin. 5 grams is the standard adult dose. It's given intravenously. In somebody that the actual dose is 70 milligrams per kilogram, up to 5 grams, and you can repeat that dose. You can also give sodium thiosulfate as well as a sulfur donor to help detoxify cyanide. And there's some other options available too if they're available, and one of those is hyperbaric oxygen therapy. But these patients that have cyanide toxicity can, if they survive to the hospital, can still and if had a significant exposure, can undergo seizures, coma, and cardiovascular collapse pretty quickly.
Many of our providers wonder about the timing of treatment for cyanide toxicity. Obviously, we have issues of getting the medication to the patient versus bringing the patient to the hospital where we can treat their cyanide toxicity. Can you tell us a little bit about how important the timeliness of treating for cyanide toxicity is?
Well, if you strongly suspect a victim has cyanide poisoning, then early treatment is, of course, the best therapy. The problem is that there's no standardized guidelines for the use of the Cyanokit, and the initial signs and symptoms of cyanide poisoning can be signs and symptoms of other disease processes, and so patients may have anxiety, confusion, headache, chest pain, shortness of breath before they go on to develop seizures, coma, and cardiovascular collapse. And so I think it's real hard to, knowing what the cost of the Cyanokit is, a lot of patients may complain of you, there's some chest pain or shortness of breath, and you can't obviously give the Cyanokit to every patient that you encounter on scene. I think unless you strongly suspect that there is cyanide involved, in particular in the setting of a fire, because that's probably where you're going to most likely encounter it, unless that person has available to them some kind of cyanide tablet or a reagent where they use cyanide. Regardless of the scenario, and I'm sure I can only envision the scenarios that you guys and gals encounter every day, and I appreciate all that you do to help us as emergency medicine providers and as a medical toxicologist, but make sure you're safe and protect yourself, particularly if you're in a situation where there may be chemicals or drugs of abuse or agents like cyanide. So you need to have that personal protective equipment because cyanide can be inhaled. About 50-60% of the population can detect the bitter almond odor of cyanide. That means the other half can't. So don't rely on that as a screening tool to rule out a potential cyanide exposure. But if you've got a victim who's down in a fire, you need to think of both carbon monoxide and cyanide and make sure you've got the appropriate protective equipment on. Also, if that patient is still alive by the time you transport, they may need to be decontaminated. Don't do mouth-to-mouth. It's kind of a no-brainer these days, but particularly if there was a chemical ingestion of cyanide or chemical form of cyanide that was ingested, because that can be on their lips.
Bryan, I'm wondering what is helpful as far as information, or when our pre-hospital providers are handing these patients over to an emergency physician, what type of historical elements, treatment elements are the most relevant from the cyanide toxicity? What information do you want to make sure is communicated?
It's a great question, Todd. I am so dependent on our EMS crew and first providers in providing a story for us on what was going on at the scene with that particular patient, particularly with a smoke inhalation victim or a toxicologic patient, because it can provide so many clues as to what that particular person may have been exposed to and help guide me as a clinician in how I'm going to manage that patient that's now before me in the emergency department. and I can run through multiple scenarios, but telling that story, gathering that information, that's a hard job to do because I'm sure it's chaotic at the scene. But by gathering your wits and collecting all the data and information you can, and then giving that to clinicians at the hospital is so beneficial in helping us do our jobs better. So it really boils down to a clear line of communication.
Bryan, tell us about cyanide levels and smokers.
Sure. So I don't think I need to preach to you, Todd, smoking's bad. It liberates, hundreds of chemicals into the bloodstream, including carbon monoxide, various metals, but also cyanide too, and cyanide concentrations that are considered potentially toxic. And I've been consulted on patients who are in the hospital who have potentially toxic cyanide concentrations, and then they're awake and talking to me, their vital signs are fine, there's no acidosis, and lo and behold, I do a little digging and it finds out they're a smoker. So just one more reason to quit if you're a smoker.
I want to thank Dr. Judge for taking the time to come and talk to us today about cyanide toxicity. I also would like to thank all of our providers who submitted questions and who have brought this important topic to the forefront. From my perspective as medical director, we have a protocol for treating cyanide toxicity. I think the bottom line is if we encounter a situation where we think a patient might have cyanide toxicity and we have access to the antidote, we want to call for that resource early. If we have it on scene, we want to administer this resource. But in the other situations, we want to rapidly transport that patient to one of our local emergency departments where they can continue to receive care.